All right. So as promised, we're going to very briefly touch about cancer in children. We could have an entire unit about cancer, and then specifically an entire unit about cancer in children. But I just want to kind of briefly touch on the differences, as I mentioned earlier this morning, the differences of why cancer occurs in children versus adults. So let's just kind of spend a couple of minutes here this morning talking about that. Here are the objectives. Now, as I mentioned, there are differences between why and when cancer develops in adults and children. We've already spent a lot of, this morning, but then also previously before the exam, talking about this interplay between genetic predisposition and the environment in adults. But as I mentioned, there's a really truly known fact that there's a long latency period usually between the time that a person becomes, exposed and then when cancer actually develops. So that's why and Kathy talked about this, a couple weeks ago too, as someone ages, cancer risks go up because obviously you've lived longer. Now those things that you've been exposed to in your teens, 20s, 30s are now coming to fruition. So that's not the case with children because we're talking about cancer in someone who's 3, 4, 5 years old. So it's not really those same reasons for why children get cancer. So let's talk a little bit about cancer in children and why that develops. So incidence of cancer is definitely more rare, obviously, for those reasons that I just said in children. But the leading cause of death from disease in children is cancer. This is kind of an old statistic, but in 2004, mortality rate was 2.4 per 100,000 cases. It's pretty good. And to be honest with you, children with cancer do better. They have better anti mortality rates than adults. And obviously, over the last I put 30 years, but probably even more recently than that. So survival rates have gotten even better and have dramatically improved, over the last several decades. The reason for that, honestly, is before, a couple decades ago, a lot of the research that they were doing clinical trials on adults, right? They were doing cancer clinical trials in the adult population and then trying to sort of apply and extrapolate the information that they learned from adult clinical trials in terms of treatments and, therapies and things like that, then just kind of apply it to the pediatric population. Imagine that. Wasn't totally successful, right? Wasn't really all that positive. Again, because of the different reasons why children have cancer. So over the last, 30 years or so, they've done a lot more research and a lot more clinical trials, specifically in the pediatric population. And lo and behold, their success has been a lot better, right? They can actually specifically apply the things that they're learning in those clinical trials to the pediatric population because it's a specific type of population. You can't just, with a lot of things, you can't just apply what works to adults and try to apply to children. So they've had specific pediatric research that now has been very positive and very dramatically improved over the last several years. Okay, but if it's not exposure to something in the environment that causes problems and that causes cancer in children, what is it? And so, as you see here, a lot of the cancers in children originate from something called the mesodermal germ layer. Anyone know what that is? Anyone have any knowledge of that? The mesodermal germ layer is really sort of the embryonic tissue that in the embryo is supposed to develop into a lot of the connective tissue kind of things. So bone, cartilage, muscle, blood vessels, etc. I have that here on the screen for you. The lymph system, etc. What happens in children who, a lot of the childhood cancers is that there's been some sort of defect in this mesodermal germ layer. So they have this sort of leftover embryonic tissue that did not get developed or did not get used up, essentially, in some of these connective tissues. And so you have this excess tissue, this excess embryonic sort of very sort of primitive tissue left behind. And so what you see is that you see a lot of sort of connective tissue kinds of cancers in children because of this defect in this mesodermal germ layer. So it's this undifferentiated sort of left behind tissue during fetal growth and development that then causes problems and sort of turns into these cancerous cells because it didn't get used appropriately and used up effectively during the embryonic growth. So most of the cancers that you see in the pediatric population are sarcomas, again, cancers of connective tissues, versus in adults you see more carcinomas. So you see things because of carcinogens and because of exposure to things in the environment. Carcinomas, as I mentioned, previously, are really rare in children because they usually result from environmental exposures, which you just don't have the time in kids to have that latency period in a 5-year-old. You're going to see those sort of carcinoma things happen more frequently in someone in their 50s and 60s, etc. In children, they're going to be, these cancers are usually most commonly diagnosed during really peak growth periods. And you're going to see really the difference between signs and symptoms in kids versus adults is that they're very fast growing, and you don't really see a lot of early signs. And the reason for that is because they're fast growing. So one day they're fine, the next day they're not, because of how fast these tumors and how fast these these cancer cells are growing. So that's sort of a good thing, but also sort of a bad thing about childhood cancers is that they just sort of pop up out of nowhere. Because they are so fast growing without a lot of warning signs. And that's a pretty common experience. If you talk to parents of children who have been diagnosed with some sort of, sarcoma, some sort of cancer, they'll literally sort of report to you, like, it seems like one day they were fine and the next day they're having these issues, right? And again, it's not that dramatic, but oftentimes it's pretty quick. It comes on pretty fast. And you'll see a lot of these things, sort of the peak incidents, occur sort of before the age of 5 years. So these are little kids. These are really young, sort of preschool age children that you'll see a lot of these things in. Okay. So again, most common childhood cancers are leukemias, sarcomas, and embryonic tumors. So tumors from that left behind embryonic tissue. Oftentimes these embryonic tumors will originate actually even during intrauterine life. So even pre the baby, being born. They can see it very early on, and in fact, sometimes they can actually see some of these embryonic tumors in ultrasound, in utero before the baby is actually born. So they'll know some of these things, prior to birth even. Leukemia is really truly the most common malignancy in children. And you'll see specific types of leukemia linked to specific other disorders. So an example that I give you here on the screen is that, interestingly, children with Down syndrome, so that, chromosomal aberration that we talked about at the beginning of the semester, children with Down syndrome have a 10 to 20 times greater risk for developing leukemia. And that's a known risk factor for quite some time, that there's a really big link between leukemia and Down syndrome. And then again, the other thing that you see a lot, more frequently in childhood cancers is sarcomas. So bone tumors. There's a couple of tumors I put here on the board: osteosarcoma and Ewing sarcoma. We're not going to talk a lot about those today because when we talk about disorders with bone in next semester, we'll talk about that. And then other common cancers. And again, I want to be clear when I say other common cancers. I mean other common pediatric cancers. These things are really rare, really abnormal. Adults don't get these types of cancers here at the bottom of the screen. But because they're sort of created from that mesodermal germ layer, or that leftover embryonic tissue, you'll see them common in children, but you're not going to see these in adults. So, neuroblastoma is a specific type of tumor in the brain. Wilms tumor is in the kidney. Rhabdomyosarcoma is muscle. And retinoblastoma is obviously the retina, so in the eye. Again, common cancers in the pediatric population, not in the adult population. Okay. So, given the conversation that we just had, given this issue of things originating from the mesodermal germ layer and from the embryonic tissue, the etiology of these cancers is not because of some sort of predisposing environmental factor. They just have not lived long enough to get those types of cancers. So it's more of your genetic factors. So chromosomal abnormalities, as I mentioned, some congenital syndromes and cancers are linked together and occur very commonly together. I mentioned Down syndrome and leukemia, but another good one is Wilms tumor, so that kidney tumor with other sort of urogenital malformations or abnormalities or structural problems in the urogenital tract is oftentimes associated with Wilms tumor as well. Again, probably because of the way that basic embryonic tissue developed. One, not only did it develop incorrectly to cause some sort of these sort of abnormalities, structural defects sort of things, but then also a tumor in that same area as well. So it kind of makes sense when you think about, the different times in sort of embryonic development, if something goes wrong in that week, of that particular system being developed, that you'd see some sort of congenital sort of structural problems and then maybe some cancer as well, because it all kind of developed in that same week of gestational life. And then I also put up here that you also, can see this issue of oncogenes and tumor suppressor genes being turned off or turned on sort of inappropriately with pediatric cancers as well. So again, usually in children, it's a cellular issue or it's a genetic issue, not environmental issues. I think that's pretty clear at this point. Okay. So what are some environmental factors? So I'm going to kind of, contradict myself here. What are some things that maybe prenatally the baby could be exposed to sort of create these abnormalities? Well, we do know that some drugs and some ionizing radiation in utero can cause some of these issues. We mentioned that whole issue of DES in the previous part of our lecture this morning, those moms who were taking DES during their pregnancy and their daughter's increased risk of cancer. That's a good example of that. But we've also seen linked to DES, again, historically, but daughters of these women had, not only do they have a higher risk of breast cancer later on in their life, but as children, they had really sort of strange adenocarcinomas as well, like GYN kind of things, like vaginal cancers and things like that, early on in life, in childhood. Again, shows you that link between environmental factors and, in utero, they can still be effective. And so even though these environmental factors are a lot less of a risk than some of these sort of mesodermal germ layer factors that we just talked about, it is possible. And here are some sort of childhood exposures that can sort of predispose children a little bit later on down the road. So secondhand smoke, ionizing radiation, certain pathogens, so viruses, Epstein-Barr virus, AIDS, things like that. And another really good example is cytotoxic agents. So here's the example that I want to give you. Cytotoxic agents, would be like chemotherapy or something like that, right? It's also a really sort of known phenomenon that children that have had some sort of childhood cancer who undergo cytotoxic therapy, like chemotherapy, etc., are at higher risk later on down the road, like in their teens, early 20s, etc., can predispose them to different types of cancer later on in life, so like leukemia. So a really good sort of clear example would be, let's say a child has some sort of sarcoma. They've got bone cancer, okay? They've been treated with some sort of chemotherapy. They've gone into remission. They've been successfully cured of this specific type of bone cancer at the age of 7. And then at 27 or 30 or a little bit later on down the road, they now have leukemia. And again, this can be because of the cytotoxic agents that they were exposed to as a child. So kind of an interesting sort of double-edged sword there. Another good example is immunosuppressive agents. So children who have been on some type of immunosuppressives for some type of treatment, maybe organ donation or I should say organ transplant, they're also more at risk later on down the road for specific types of cancer because their immune system has been depressed. Therefore, their immune system is not kind of running surveillance for these bad abnormal cells and abnormal cellular growth, and they're at risk for things like lymphoma. So again, there is a link between childhood exposure and specific types of cancer as well. So even though this slide sort of contradicts everything that I just said, saying that it's not environmental factors, it's the embryonic, germ layer of their tissue, there can be some things as well that we can't sort of not talk about when we're talking about childhood cancers. Okay, so again, we're not going to go into specific, types of cancer today because we're going to talk a lot about these things when we're talking about other systems as we move through the rest of the year. Like when we have our bone lecture, we'll talk about bone cancer, etc. But let's talk a little bit in generality. So prognosis for children, pediatric population with cancer, really good, actually, prognosis. So more than 70% of diagnosed children are cured. And that doesn't say that they won't have issues later on down in life, like we just talked about. But the actual cancer at that time, 70% that are diagnosed are cured. Survival rates are higher in children when they've been diagnosed under the age of 15. Again, interestingly, we said this kind of at the beginning of the lecture as well, children tend to do better than adults. Younger children also tend to do better than older children. Anyone kind of have a theory or a reason for why that might be? Yeah. Right. Perfect. I couldn't say it any better than that. The younger you are, the higher rate your cells are kind of turning over and dividing and regenerating and renewing naturally anyway. And they do better. They honestly do better. So that's why there's, some different rates that you sort of have to think about with kids versus adults, and they actually do better because their cells are just newer and renewing quicker and regenerating faster, and they almost sort of, I don't want to say heal themselves, but they just do better with the treatments. Think about it. We talked about chemotherapy and how it wipes out all of your bad cells, but also all your good cells in terms of white blood cells, red blood cells, those types of things. Kids who are regenerating faster, they're going to regenerate those cells better, right? Even the good cells that get wiped out are going to be regenerated faster, better, quicker, because they're kids. Younger children are more likely to be enrolled in clinical trials, which is just kind of a phenomenon, honestly, probably because of parent involvement and wanting to do as much as they can for their children. We talked about how survivors do have an increased risk of cancer later in life. Another big difference between kids and adults is the residual and the long-term effects of treatment for kids. A 70-year-old man is probably not going to live long enough to see some of the residual and long-term effects of chemotherapy and some of the treatments that they have used to sort of cure his cancer, as opposed to a 5-year-old little boy, right? He's got his whole life to live. So there might be some residual problems and some long-term effects of treatment that are going to apply to children because they still have their whole life to live with some of these long-term effects, as opposed to someone in their 70th decade of life. They're probably not going to live long enough to see some of those things play out. So things like, they're doing a lot of research in pediatric oncology now regarding some of these long-term effects. So things like physical impairments. What kind of physical impairments is this 5-year-old going to have down the road because of treatment and because of the way they have sort of addressed and sort of attacked this cancer? Is there going to be reproductive dysfunction because of radiation and chemotherapy? Will this 5-year-old little girl who's undergoing chemotherapy have issues with fertility when she's 30? Those types of things. Soft tissue and bone atrophy in places that have been irradiated, or things like that. Learning disabilities. This is a really interesting new sort of interest in research, looking at how does those cytotoxic agents and all the things that sort of their little body becomes in contact with early on in their life affect learning, affect their cognitive function, affect those types of things as they grow up and get older and go to school and things like that. Is there psychological sequela and psychological impact that will impact a child as they're going through their sort of developmental stages way sort of heavier, way greater than, again, a sort of already grown, already developed 45-year-old, right? So what kind of psychological impact is there in children as opposed to an adult going through some of these really sort of dramatic, difficult periods in their life in terms of their health, but also emotional well-being, seeing their parents upset, seeing their parents suffer, those types of things can play a really big impact on a 5, 10, year old as opposed to a 45-year-old. So really interesting differences, really, between the way we address and the way we attack and the way we sort of treat cancer in children, and then what that means for them later on in life as opposed to an adult. So kind of interesting things to think about. They also sometimes, the reason that they have such a good sort of diagnosis and prognosis oftentimes is the way in which they treat childhood cancers. They're oftentimes more aggressive with children, again, because they have their whole life to live. Clinicians see the promise, they see the potential, and so oftentimes they'll be pretty aggressive. So they'll use a lot of combination chemos, so different types of chemos and multimodal treatments that kind of come at a tumor from all different angles and all different ways. They also have done, again, because of the research being done specifically in childhood cancers, there's been a lot of improvement of supportive care and, looking at, all the different other types of care that a child needs while going through treatment and suffering from cancer and things like that. So again, just kind of some interesting things to think about that does really make kids different than adults during this process of treating cancer. And then, here, so as sort of the last slide, I really did kind of just put up some of the sort of, versus kind of thing. So adults versus kids. Incidence for adult cancers versus the incidence in child. The risk factor for environmental lifestyle higher in adults than in kids. Just kind of underlining and rescoring some of the things that we've talked already about this morning in terms of the differences between kids and adult cancers. But again, we could talk about this for a long time, and we could have an entire unit about this, but I really wanted to just kind of give you some fundamental information regarding this topic. And again, the reason that this is good to know, and the reason that I wanted to spend some time having this conversation not only both on the adult population but in the kids this morning is, the way that we can educate our patients. What we know, and if you know better, you do better, sort of things, right? And so if you can be as educated as you possibly can about links to certain cancers or links to certain lifestyle factors, we can then sort of better educate our patients, better prepare our patients, and their health practices and their lifestyles and things like that. And again, just to kind of rescore this whole issue of that childhood cancer is sort of its own different beast, right? As a nurse taking care of a pediatric oncologic patient, it's a very different experience, or shall I say, can be a very different experience to be a pediatric oncology nurse as opposed to the adult population. So just kind of wanted to bring some of those differences home today and kind of discuss some of these things so that we, again, can be better educated for our patients. So that sort of concludes the topic of this lecture today. And we do have a few minutes here. So I wanted to just kind of quickly discuss as a group that article that I had posted on my Friday notes. I'm not sure if anyone got a chance to look at it or just sort of skim it or read it. It's a really interesting article that actually, it's now a couple years old, actually. I guess it was 2 years ago this time of year. I was very serendipitous. I was getting ready for this lecture and, doing my research and prepping my notes and getting ready for this cancer epidemiology talk. And I get a subscription to New York Magazine, and right on the cover of the magazine was this, the cancer drug bracket, right? And I love the thing at the bottom here is $75,000 to extend a life for 42 days. ? Doctors revolt, period. And I thought, this is sort of interesting. So I read the article, and it was just sort of really perfect timing, and I brought it in and discussed it with my class like that next day. And so since then, I like to bring it in, especially because we usually have a little bit of extra time at the end of this lecture, and it's just very sort of good timing where you can sort of bring in what we've learned in class and what you will be learning. I don't think you've gotten like cancer drugs yet in pharm, right? No, you will be. And so I just kind of like to bring it all together. So what we're learning in class to the real world and what's being written about in, pop culture and things like that. So that being said, let's discuss this article a little bit. Did anyone have a chance to look at it, and would anyone like to kind of recap for the group a little bit about this article so we can kind of discuss as a group? Anyone? Throw in your 2 cents? Yeah? I see you were on the edge of your seat. That's fine.
I'm not great at reading retention.
What do you think it was about?
Okay, so it's about this guy or company that created a cancer drug that was similar to another cancer drug that the old cancer drug cost $5,000 a month.
Mm-hmm.
And to take this drug, if you take this drug, it can extend your life 42 extra days. But you also, it's not like you just start taking that drug on day 1 to 42. You
Right.
have to take the drug
For months.
Right.
Right.
Prior.
Mm-hmm.
So you're spending all that money
Right.
for the little extra time. But then this guy who created this other drug gave a whole lecture on it, was starting to kind of spread the news about it, and then a physician went to him and said, you realize that this drug is actually double the cost of that other drug. So it was $11,000 per month for the same experience of having to spend do it for 7 or so months before
Right.
for this 42. So it was the first time, and so this guy said, I wouldn't advise this, sent out to all the physicians to the hospital, I would not advise you to use this drug.
Right.
So the guy who developed it said that he wouldn't. So it was the first time in history for
It wasn't necessarily the guy that developed it.
Maybe not.
But yes, yes.
the first time that physicians were
Yes.
deciding to take cost into consideration.
Right. Good. Okay.
For something that works.
Right, exactly. So there's this new drug, and again, this is a little bit old news now because this happened like a couple of years ago. But there was this new drug called Zaltrap that came out on the market for sort of a second-line cancer treatment. So that means that it's not going to work by itself. You have to sort of, one, you're using it like after everything else has kind of failed, and two, you have to use it with other chemotherapeutic agents. So it's not, it's not going to just sort of work on its own. You have to use it with some other things in conjunction. There's this new drug that came out called Zaltrap that was very, as you were saying, very similar to another drug called Avastin that had been out on the market and had been used for quite some time, again, as a second-line drug. So again, not a wonder drug. It's not working beautifully by itself. You have to kind of use it in conjunction with other things. But the issue was exactly that it was almost double, if not triple, the cost of this other previous drug. And yes, it's the newest, greatest, best, cutting-edge medication. And so, of course, if you're a patient who's stage 4 cancer, who knows there's not a lot of more hope for you at this point, are you going to want to try it? Most people are going to say yes. Most lay people who want to try anything, who are desperate at this point, are going to try it. The issue is that it only, even if you take it for months and months and months and months, the research, the clinical trials said that the overall survival of taking this drug that will literally cost you $75,000 over a few months would only extend your life to 42 days. And this physician that Taylor was talking about was one of the big head physicians, colorectal physicians at Sloan Kettering. It's the sort of premier cancer hospital in New York City. He's the one that said, no, we're not going to use this drug here. This is ridiculous. Because the way he saw it was, one, it's not really improving the sort of survival rate that much. Second of all, you're going to completely bankrupt your patients who are trying to take this. And third of all, it's a racket, right? Unfortunately, the way he saw it, and I would tend to agree with him, cancer drug companies oftentimes see the desperation in their population. They see the desperation of these patients, and they know that they can charge whatever they want to charge for these medications because these patients are desperate. And they will do it for the sake of saying, I got to try it because I won't know if I don't, sort of thing. And so the whole point of this, and the thing that sort of struck me when I read this article for the first time, is this is one of the premier cancer physicians at one of the premier cancer hospitals in the world refusing to carry this new top exciting popular cutting edge drug at their hospital, all because basically the ethics of what's the price of hope, honestly, really what is the ethics of just charging. He's like, I'm not willing to make my patients or my patients' families pay this for what? And the big question that I have too is, so, one of the big things as a clinician whenever I was reading this article is that, okay, extend your life up to 42 days. But what's one of the questions that pops into your head when you think of, okay, you're extending a cancer of, a terminally ill, stage 4 cancer patient's life by 42 days? What questions pop into your head? Yeah. What are those 42 days like? Right, exactly. And that's what this physician was saying is, I'm going to be charging my patients, or probably my patients' families, because this patient's going to die. I'm going to be leaving this family with this legacy of $75,000 up to almost $1 million sometimes in some of these cases in debt to extend this patient's life 42 days. And what is the quality of what is the quality of those 42 days? Right. So there's the ethics of that as well. So tell me a little bit about, so even if you didn't read the article, if you did or if you didn't and you're just sort of hearing us recap it, tell me a little bit about some of the things that sort of pop up in your mind in terms of issues or red flags, or do you agree with this physician? Do you not agree with this physician? Again, kind of tying in what we've been talking about in class now to the real world and to decisions that physicians and nurses and hospitals and drug companies have to make every day. What are some things that pop up to you as we discuss this? Anything? Mm-hmm.
Wasn't this new drug as effective, or the old drug as effective as the new drug?
Yes.
So I feel like if the old drug is just as effective and half the cost,
Right.
then it's totally reasonable
Right.
to consider costs.
Absolutely. Right, exactly. Very good. Yeah, and that was one of the things, though, that the drug companies were sort of fighting against this physician, saying, no, but it is the newest and the greatest and the best, and we do have to charge this because of all the cost of research and getting it passed through the FDA and all the red tape and all the cost. It's a costly process, so yes, we have to charge this. And he was basically saying, BS. You know, it's not doing anything that the other things on the market aren't doing, and you're preying on people's hope. You're preying on people's desperation for hope. Right, very true. Yeah. What other things come to mind? Anything else? You know, like I said, I think one of the things that makes me the most mad is that, you know, as this article goes on to talk about some of the prices of other kinds of cancer drugs out there, is that honestly, cancer drugs throughout history and throughout sort of the last 10 to 20 years have not increased because of market changes. That it's not just sort of risen because of inflation. The prices are rising because they can. Because the prices go unchecked because patients are willing to pay crazy prices because of the desperation of hope. Yeah. Right. 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 So, you know, and I think that's one thing, too, that I think I have learned as a clinician more so than probably lay people maybe think about or even sort of realize, is that you have to put a value and you have to really think about this whole issue of quantity versus quality. And I think most people in the population, if you say 42 more days, everyone's going to be like, oh, great, wonderful. But until you have seen that patient suffering and you've seen that person lying there and you've seen what it does to the family and you see what it does to their body, and you know that 42 days does not just mean 42 days. And I think you have to, I think you're right. I think you have to do a really good, quick job of educating your patients and their families about that. Because of course most people are going to want 42 days until they know realistically what those 42 days look like. Right. Very, very true point. Very good. Yeah. Okay. Yeah, you know. Right. Right. There's all that familial pressure too. Right. Right. Like realistic, you mean? Yeah. Mhm. Mhm. Of course. Right. Mhm. Interesting. Right. You will. And it, you know, and what in my experience, what I have found is that the most difficult situations and the most difficult conversations are when the patient and the family are not on the same page. When someone is saying enough is enough and the other one's saying let's keep going, then you're talking about some major conversations that you know, we as nurses are there for. I mean, we are there at the bedside witnessing this family dynamic. You know, witnessing these sort of issues going on between family members. And again, if that's going on, if this sort of discourse and upset in the family dynamic is occurring in these 42 days, what kind of 42 days is that as well? We're not even talking about the physical aspect of the pain and the suffering of the actual disease, but the sort of familial dynamics that go on during those last few days as well. Right. They kind of be strong and go with the flow during the day when everyone's pushing certain things, and then at night they can really be honest with you. Yeah. Yeah. Yeah.
Actually, it's something that happened last night. You know, while you're watching all these commercials and pharmaceuticals,
Yeah. Oh yeah.
And I just know that this country is like, that's the pharmacies don't usually advertise to the public, to the like, population of other countries, it's only in America.
Mhm.
A lot of people have this idea that doctors, by prescribing these medications, get kickbacks and, the pharmaceutical company, they give them more money. So I
Right.
think it's really monumental that that doctor was like,
Yes.
no,
Yes.
this is not okay, because people don't think that doctors are people.
Yeah, and actually that's a really good point that I kind of forgot to mention. I don't even know if they necessarily talk about it in this article, but a year later, so again, this was 2 years ago that I read this article, then last fall about this time, there was a piece on these exact same doctors in this exact same situation on 60 Minutes, and it was sort of a follow-up piece really to this article. And I think not so much in this article, but in that 60 Minutes piece, they talked about how doctors do get a kickback from this drug, and so the pharmaceutical companies we're obviously pushing it to the physicians. I mean, my gosh, think about the kickback of this expensive drug. Think about the money that the physicians are getting back for that. So there was a lot of ethical issues regarding that as well. And then when this physician said, no, I'm not doing it, then the pharmaceutical company was sort of saying, like, trying to, like, find a different way around it. Like, okay, we won't charge the patients as much, but we'll still charge sort of the hospital for it, and then you can still get the kickback for that full market ticket price, so to speak, and yet the patient, I mean, they were just trying to go about it in all different ways to try to get their money, essentially. And I think it's evil. I mean, it's awful. And so the fact that this very powerful physician and this very powerful institution went to bat for the patients says a lot. Yeah, I think it's huge. And you're not going to see that all the time. Yeah, very rare. That's a very good point. Very, very good point. Anything else? Any other yeah.
So if they're getting so much benefit from research, shouldn't that like lower the price from pharmaceuticals so they can still have they have used so much for this and this and this, but shouldn't that kind of overlap?
Well, right. I mean, there's so much. You mean there's so much funding and there's so much support for a lot of these trials and research. Is that what you're saying? That why would it be that expensive? Yeah, you're right. It's all, and it has everything to do with it. They have the market in their grips and they can do whatever they want with it. Yeah, which is again another really bad ethical consideration regarding these pharmaceutical companies. Do we have a question over here? No? Okay.
I think it's a good point, though, is to read that recent CEO of a pharmaceutical company that was selling HIV drugs for $75,000 a bottle, and how much kickback he got, and his stocks crashed. There is a limit to saying that this is ridiculous.
Yeah.
It's kind of like this holier than thou thing.
Right.
You say, like, I have this here, but only it's like gambling.
Right.